Welcome. Today's FERNE educational opportunity discusses the Dizzy Emergency Department patient and the Grace 3 guidelines which come to the rescue of the emergency clinician. My name is Edward Sloan. I'm an emergency physician from Chicago. I'm Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. I'm Medical Director for the Physician Assistant Studies Program at Dominican University, and I'm Medical Director for New Rose Healthcare Management, which helps the staff an emergency department in a safety net hospital on the south side of Chicago. Thank you to the EIM group, the group that initially supported my presentation of this information in December of 2022. I have no financial conflicts. I'm the FERNE President and Board Chair. FERNE has educated emergency clinicians for 2 decades in how to optimize the care of patients with neurological emergencies and injuries. What is the Grace 3 recommendation regarding emergency clinician training? Grace 3 training. Emergency clinicians should receive training for diagnosing and treating patients with acute dizziness. In other words, do some training and education. This actually is part of your training. If you listen to these FERNE sessions, you will learn more about how to optimally diagnose and treat patients with dizziness and vertigo. Knowing this Grace 3 guideline improves patient care, and using any algorithm enhances the diagnostic and treatment values of your ED strategies. What about Grace 3 and the acute vestibular syndrome patient? What is the Grace 3 recommendation regarding the use of HINTS testing in AVS vertigo patients? In patients with nystagmus, that is, acute vestibular syndrome patients who have nystagmus, trained clinicians should use HINTS testing to distinguish central, i.e. stroke or TIA, from peripheral, inner ear, usually vestibular neuritis diagnoses. There is a high certainty of evidence related to this recommendation that suggests that HINTS testing be done. Let's discuss this more. In acute vestibular syndrome patients, if there's no nystagmus, then the acute vestibular syndrome should be thought to be due to a central etiology. In other words, HINTS testing is only to be performed and is reliable in acute vestibular syndrome patients who have observed nystagmus in the emergency department. The HINTS exam is not difficult. It is easy to master, and we know based on the published literature that the HINTS test has a high sensitivity for detecting a central etiology such as stroke in patients with acute vestibular syndrome and nystagmus. What is the Grace 3 recommendation regarding hearing testing in acute vestibular syndrome vertigo patients? In patients with nystagmus, assess hearing by finger rub to distinguish central from peripheral etiologies and diagnoses. There's a moderate certainty of evidence published that supports this recommendation. In other words, the emergency clinician is encouraged to do a finger rub to assess acute hearing loss in patients with acute vestibular syndrome. Let's consider this a little more. The HINTS Plus exam, the plus being the hearing part, is indicated and verified again only in acute vestibular syndrome patients with nystagmus. Acute hearing loss in this setting may suggest a central etiology such as stroke from posterior circulation problems. And note that Meniere's disease and labyrinthitis may also have associated hearing loss, but it may be more subacute, that is, not acutely occurring with this episode of severe persistent vertigo in AVS patients. What is the Grace 3 recommendation regarding gait testing in acute vestibular syndrome vertigo patients? In patients without nystagmus, assess the severity of gait unsteadiness to distinguish central from peripheral diagnoses. There's moderate certainty based on the published evidence. In other words, Do gait testing in acute vestibular syndrome patients without nystagmus in order to assess or confirm a suspected central etiology. Let's consider this gait testing further. If there's no nystagmus in a patient with acute vestibular syndrome, a central etiology should be considered and confirmed to observe ataxic gait. In acute vestibular syndrome patients without nystagmus, you can assess for truncal ataxia, which would be leaning over, not able to sit up straight in the cart, or ataxic wide-based gait. These are often present and would confirm a central etiology. So in other words, it's important to sit the patient in the cart without support to see whether they can sit upright. It is also essential to walk the patient when able, and to walk the patient and observe the ability to walk unassisted when considering discharging the acutely vertiginous patient from the emergency department to an outpatient setting such as home. What is the GRACE 3 recommendation regarding CT and CTA use in acute vestibular syndrome vertigo patients? In patients with or without nystagmus, the guidelines state do not routinely use non-contrast brain CT or CTA. There's a high certainty of evidence for this recommendation. In other words, in patients with acute vestibular syndrome, acutely, severely dizzy in the emergency department, do not do a CT or CTA for these patients. Now let's consider that. CT and CTA are generally not helpful in distinguishing central from peripheral etiology for acute vestibular syndrome vertigo patients. Vertigo is not uniformly related to pathology that is visible on a plain brain CT or non-contrast CT, or even a vessel study such as a CTA. What is the GRACE 3 recommendation regarding MRI or MRA use in acute vestibular syndrome vertigo patients if HINTS testing is available? The recommendation states, in patients with or without nystagmus, do not routinely use MRI or MRA as the first-line diagnostic test if a clinician trained in HINTS testing is available. There is a high certainty of evidence for this recommendation. In other words, if HINTS testing can be performed by an adequately trained clinician, do not do an MRI or MRA in acute vestibular syndrome vertigo patients. Let's consider that a bit more at length. Remember, the HINTS Plus exam is the best diagnostic test to be performed in acute vestibular syndrome patients. It has a higher sensitivity than MR at detecting a central cause of vertigo. In other words, when able, have a clinician do the HINTS Plus exam and train clinicians to do the HINTS Plus exam, given the fact that it can be performed adequately with only a nominal amount of training. Please note again that when there is absolutely no nystagmus, the ability of the HINTS Plus exam to adequately diagnose a central cause is less assured than when the patient with acute vestibular syndrome has vertigo noted on exam. What is the GRACE 3 recommendation regarding MRI and MRA use in acute vestibular syndrome patients if HINTS testing results are uncertain or unavailable? In patients whose HINTS test or result is either suggestive of a central etiology or equivocal, use MRI or MRA to distinguish between central and peripheral diagnoses. There is a high certainty of evidence saying that you should do an MRA in AVS patients if the HINTS test result is in any way uncertain. Let's consider that more. If the HINTS Plus test does not confirm a peripheral etiology, then a central etiology should be suspected. What is an equivocal HINTS exam? It's an exam that has variable testing results upon repetition and/or results that do not appear or suggest a normal peripheral vestibular system functioning. To confirm a central etiology for acute vestibular syndrome vertigo patients, then an MRI/MRA test should be done. What are the Grace 3 summary recommendations for acute vestibular vertigo patients? This is a great slide that summarizes what we know based on the Grace 3 recommendations in acute vestibular syndrome vertigo patients. It says, use the HINTS exam when possible. Otherwise, if you have to, do an MRI DWI study. If you think there's a stroke diagnosis, do the MRI DWI study. And lastly, do not use CT or CTA or CT perfusion in these patients with acute vestibular syndrome vertigo. The MR DWI test gives the best ability, when HINTS is not available, to diagnose the location or possible cause of a central diagnosis related to acute vestibular syndrome vertigo. For more information, email me at ferne.org@gmail.com. You can go to our ferne.org website or find us at FERNE.org on our social media. We have this content posted on our YouTube channel, and it's available in the small 1-minute lectures on TikTok and Instagram. You can also find us on X, Facebook, and LinkedIn. Thank you for your participation in this educational opportunity today.